Okay, let's just dive right into this. We're going to be moving rapidly through our agenda today. Laparoscopy basics, abdominal access, energy sources, physiologic effects, robotic surgery, and finally, flexible endoscopy.
Module 1. Laparoscopy Basics. Creating Working Space.
So, a highly testable concept right off the bat is patient selection. Believe it or not, there are actually surprisingly few absolute contraindications to laparoscopy. They're basically limited to the inability to tolerate general anesthesia, uncorrected coagulopathy, and hemodynamic instability. That's pretty much it. Everything else, things like bowel obstruction, peritonitis, or loss of domain, those are considered relative contraindications. This distinction is absolutely crucial for your exams. Basically, unless the patient is hemodynamically or anesthetically unstable, laparoscopy is very often still on the table.
Right, so once we're actually inside, port placement is governed by the principle of triangulation. Think of this as the spatial foundation of laparoscopic surgery. Because you're taking a 3D surgical field and flattening it onto a 2D monitor, you obviously lose that natural depth perception. Triangulation is what compensates for this. It ensures your working instruments converge precisely at the surgical target without, crossing swords with each other or accidentally blinding the camera.
You absolutely must take a systematic approach to troubleshooting insufflation. Truly, just memorize this logic. If you're seeing that excessive pressure is required for insufflation, your top culprit is usually that your needle or cannula tip just isn't in the free peritoneal cavity. On the flip side, if you have poor insufflation, you need to check for things like open stopcocks, maybe an empty CO2 tank, or a leak right at the ceiling cap.
Moving on to Module 2, Abdominal Access, the most critical step.
Now, we have two primary strategies here. The closed technique utilizes what's called a Verus needle. This is a blind entry using a sharp, spring-loaded needle, which is typically placed at the umbilicus. Contrast that with the open, or Hasson technique. The Hasson uses a blunt obturator and goes in under direct vision. So, the absolute crucial takeaway here is this. If your patient has had prior midline surgeries, you've got a high risk of adherent viscera. In those specific cases, the open Hasson technique is strongly preferred for safety.
Now, if you do decide to go with the closed Verus technique, your methodology has to be exact. First, you lift the abdominal wall. Second, you insert the needle completely perpendicular to the wall. You're actually going to feel two distinct pops as you cross the midline fascia and then the peritoneum. Third, you've got to perform the saline drop test. The saline should flow easily right into the abdomen without returning. And finally, begin your insufflation at a nice low flow rate of 1 to 2 liters per minute. Your initial pressure should literally never exceed 10 millimeters of mercury. If it does, stop. Your needle is in the wrong place.
And well, this brings us to a critical clinical emergency. Listen closely. If you insert a trocar and suddenly encounter an immediate rush of blood, you have to assume a catastrophic vascular injury. Do not remove that trocar. It's highly likely that the trocar itself is partially tamponading the injury. You need to leave it exactly where it is and perform an immediate open laparotomy. No hesitations.
Let's transition to Module 3, Energy Sources, Meticulous Hemostasis.
Okay, you absolutely must understand the physics of electrosurgical complications for the exam, specifically the concept of coupling. Direct coupling happens when current purposefully or even inadvertently passes from a monopolar instrument straight through another conductive instrument. Capacitive coupling, on the other hand, is a bit trickier. This is where current actually stores up in an active electrode and then discharges through an uninsulated conductor. Think of a hybrid plastic and metal trocar. The scary part? These unseen points of insulation failure can happen completely outside your camera's field of view, which can lead to absolutely disastrous delayed bowel burns.
To mitigate those risks, we rely on specialized energy devices. Bipolar devices, for instance, contain the target tissue directly between two electrodes. This allows you to safely fuse and seal vessels up to 7 millimeters in diameter, and it does so with very minimal thermal spread. Then we have argon beam coagulators. These use ionized gas, which is just incredible for achieving hemostasis over large, raw, bleeding surfaces. And finally, ultrasonic devices. These use high-frequency vibration. They also have very little thermal spread. But hey, be warned, the active blade becomes physically hot. It actually requires a cool-down period before you let it touch anything else. Otherwise, you're risking a serious inadvertent burn.
All right, Module 4, Physiologic Effects, Systemic Hemodynamics.
So the absolute easiest way to remember this for your exams is that pumping CO2 into a closed abdominal cavity generally increases pressures and decreases volumes. Let's break it down. Cardiovascularly, compression of the aorta increases systemic vascular resistance, while caval compression drops your venous preload. Respiratorily, pushing that diaphragm up decreases pulmonary compliance and spikes thoracic pressure. Plus, the CO2 itself causes hypercarbia. Renally, the increased pressure reduces afferent flow, which drops the GFR. And neurologically, that high intrathoracic pressure actually backs up venous return from the brain, leading to an increase in intracranial pressure.
Moving into Module 5, Robotics Surgery, Computer-Assisted Systems. Now, there are definitely significant trade-offs to this master-slave computer-assisted technology. The advantages? They're staggering. We're talking wristed instruments that literally exceed human flexibility, tremor scaling for microscopic precision, true 3D binocular vision, and just massively reduced ergonomic stress for the surgeon. But the limitations are equally significant. For one, docking the cart can seriously limit your ability to quickly access multiple quadrants of the abdomen. The systems are, of course, incredibly expensive, but most importantly for the surgeon using it, there is minimal haptic tactile feedback. You have to rely almost entirely on visual cues to gauge your tissue tension.
In our final module, Module 6, Flexible Endoscopy, Diagnostic Interventions.
You really need to know your tools here. Gastroscopes, used for upper GI work, are roughly 90 to 110 centimeters long and typically feature a single working channel. Colonoscopies obviously need to navigate a bit further, so they're longer, up to 170 centimeters, and they have a thicker diameter. But remember, successful advancement of either of these scopes relies heavily on active insufflation to actually open the lumen and continuous irrigation to keep both your camera lens and the mucosa perfectly clear.
And just like with laparoscopy, you need to know how to systematically troubleshoot. Say you have absolutely no insufflation. Well, your umbilical cord might not be fully seated, or maybe the valve is just stuck. If you've got a clogged valve, you literally need to take the whole thing apart, clean it, and flush the channel out. Guys, these are classic super high-yield simulator and board exam scenarios, so lock them in.
Okay, let's do a rapid knowledge check to really lock this in. Thinking back to our abdominal axis module, what is the ideal, safe, intra-abdominal pressure target when you're insufflating during a laparoscopic surgery? Think about it for a second. Got it? The target is firmly set right at 12 to 15 millimeters of mercury. This specific range is exactly what provides the optimal balance. It gives you adequate working space while minimizing all those adverse cardiovascular and respiratory physiologic effects we just discussed. So let's wrap up with a final thought that kind of integrates everything we've covered today. If creating a pneumoperitoneum increases central venous pressure, which in turn decreases venous return from the brain and actually raises intracranial pressure, how exactly might this present clinically in your patient when they wake up in the recovery room? It's a great question. Keep that physiological reality in the back of your mind because it's the exact reason you might occasionally see temporary post-op confusion after really long laparoscopic cases. Keep studying hard, and we'll catch you on the next explainer.